The next lecture is by Professor Myers. Hello, sir. Do you have my voice?
Yeah. Yes. Hello. Hi. I can hear you.
Welcome. We are very glad to have you. You should have access to the share option at the bottom of your screen, and you can start whenever you're ready. I have to ask permission of whether it's okay to share the video of your lecture because we are recording. Is it okay if we share this on YouTube and also share the video with the participants after this?
Yes, it is okay.
That's very great. Thank you, sir. Start whenever you're ready. Okay, we have the slides.
Okay, now it's on the presentation? Now you.
Yes, it is.
Okay, all right, let me go ahead. I'm just checking my watch. I don't want to go over time. Hello, everybody.
No.
I'm delighted to be here, and thank you so much for inviting me. I've been asked to talk about suicide in physicians, and that's what I will do in my 20 minutes, and then we'll have 10 minutes for questions. So I pardon myself for having to speak so rapidly, but I want to make sure that I cover quite a few things. So no conflicts of interest. Those are my learning objectives, so that I'm hoping that I'll be able to summarize some of the things that put us at risk of self-harm. I'm going to talk quite a lot about stigma, because that's very, very important. And also I'm going to talk about ways that we can strive for wellness and resilience. Just to set the stage, these are a couple of things that I picked up from Google Scholar. Silent suffering of tragic suicide among medical residents. I was really shocked to see this. As reported, 16 residents have taken their lives. This is published in 2024, so that's very recent. And they speculate about some of the concerns having to do with salaries compared to other parts of the world, placements in remote and difficult to reach hospitals, and also first-year residents working exhausting schedules. Every other day, up to 36 hours of continuous work. There were quite a few papers. I just wanted to highlight a couple. This one and the second one lists some of the causes and solutions of medical students and residents' suicides. And you can see on the left, they're listed there, the pressures, workload, peers, senior colleagues, lack of support, again, stigma, I'll talk about that, salary, and no health insurance. And over on the right, they list quite a few nice solutions, actually, of some of the things that could be done and should be done. I hope that those are works in progress. These are things that we have tackled over the years ourselves to try to make training a more humane experience, obviously, and not have to result in such tragedies. So in terms of DSM diagnoses, the things that, oh, by the way, it's felt that roughly somewhere between 85 to 90% of individuals who take their lives have been living with some type of psychiatric illness, whether it's been recognized or untreated or partially treated. And so this is why I wanted to list the things that can put us at risk. I also want to say, too, that it's felt that there's no one reason why a person attempts or completes suicide. It's got to do with a whole confluence of factors, largely biopsychosocial factors, coming together all at once in a so-called perfect storm. It's a horrific storm, obviously. The person's overwhelmed and sometimes impulsively takes their life. Okay. That said, mood disorders, anxiety disorders, possibly burnout, the jury's out on that. Burnout is being researched heavily around the world. Substance use disorders, that varies by country. PTSD, unrelenting and progressive medical disorders, especially in older physicians or middle career physicians. and then personality deficits and personality disorders, narcissistic, antisocial, borderline. Now, apart from diagnostic variables, what are some other things? Okay, we've just learned about the acute and chronic stress of medical training and practice. An earlier psychiatric condition may occur. Somebody who's maybe had a diagnosis of something in childhood or adolescence, then has a repeat of that comes during training or beyond. Maybe an inability to recognize that some of us do have biopsychosocial vulnerability to a mental illness, and that can put us at risk as we do our training and careers. Trauma and loss that's been unlooked at or unresolved. There's an ethos in medicine of being strong and tough and always being in control. Very hard to acknowledge some vulnerabilities on ourselves, and very hard to ask for help. I'll talk about stigma. And Dr. Mann, I understand, talked about to your group yesterday. I'm sure he talked about the stress diathesis model of suicidal behavior, because as we know, not everyone who gets quite ill actually develops symptoms of suicide. So what else puts it at risk? Let me talk about perfectionism just for a moment. As you know, you have to be somewhat perfectionistic to even be accepted in the medical training. And then beyond that, to continue to do good work and practice safe and competent medicine. However, it's double-edged, because if we are too perfectionistic and we don't cut ourselves any slack, as we say in America, then we can get depressed, we can get upset, and can be very, very hard on ourselves. So that can be a risk factor. Altruism. Many doctors look after their patients much better than they look after themselves. A lot of doctors strive for autonomy, and they have trouble asking for help. They like to be independent. When we become ill, it's hard to be a good patient. And I don't mean I don't judge by that. It's just that we're busy. Or it's a reminder of stigma if we have to take medication or if we have to go see the doctor. And so sometimes we try to cut corners when we're under the care of a health professional. The culture of medicine. I think it was hinted at in those two earlier slides. There's this survival of the fittest. There's bullying that occurs in training. That's part of the hidden curriculum, by the way. Sexual harassment that's still with us, despite the fact that we've known about this for some decades now. And so-called microaggressions that are the hurts and insults that people who are minorities, racial, ethnic, religious minorities, sexual orientation, gender identity minorities, can feel these microaggressions. The burnout drivers are the moral injury. That's when we have to compromise our moral principles because of the pressures of medicine. We had felt this in the early weeks of the COVID pandemic, when there wasn't enough, for instance, PPE to go around, and where doctors were overworking and at risk of becoming COVID positive themselves. And then huge systemic pressures in today's medical world. So it's a lot, right? Now, these are some other things. Because we've studied toxicology and we've looked after patients sometimes who've taken their life, we know how to kill ourselves. And that can be a risk factor. I've looked after doctors in my practice who have told me, if I kill myself, I'm going to do it very strategically and very carefully, because I've looked after too many patients with botched suicide attempts in my practice. We have access to means. We can self-prescribe. We can get syringes, IV apparatus from the hospital, insulin, potassium chloride, some of the things that doctors use to take their lives. And then the work of the famous psychologist Thomas Joyner is acquired capability. In certain branches of medicine, we get so used to trauma and suicide that we don't seem to be afraid of it as the average person in the general public is. My book, Why Physicians Die by Suicide, the reason I wrote it, I've highlighted in yellow because the stigma in of medical illness in the medical field is everywhere and is very dangerous. And in my research, I can't tell you the number of physician families I spoke to after their loved one had died, where their loved one refused to get any medical care because of stigma. And this is why we have to fight this with urgency and might, because it is true that doctors are dying of treatable medical and psychiatric illnesses because they're afraid to go for help. And we're unique in our branch of medicine and psychiatry because I've never heard, I have a lot of friends who are oncologists. I said, have you ever heard of a doctor dying of cancer who didn't go at least to an oncologist at least once for a consultation visit? And they said, no, I've never heard of that. Well, we see it in psychiatry. And that's why we have to fight stigma. So I urge everyone to read this paper, The Lancet Commission. It was published a couple of years ago, now 3 years ago. It is a wonderful, wonderful overview and up-to-date look at stigma across the world. Now, to reduce, I want to now talk about stigma in medicine. And I've reduced this to the external stigma, that's the stuff outside, and the stigma that occurs inside us. That's what we feel, that's the interior stigma. So let me just talk about the external stuff first. And that's when we're discriminated against because of having a psychiatric illness. We're perceived by others, sometimes colleagues, as being unacceptable or inferior. Those references, by the way, are available on my website, which I'll give it to at the end for your reading. I've written about this quite extensively. You know, an example that we have in America is having to be asked a lot of questions about our health history when we apply for our medical license for credentialing at hospitals. And so there's a lot of effort now, and I gave 3 articles there, how we're fighting to get those questions removed from the application so that therefore doctors won't be afraid to go for psychiatric help. There are a lot of variables attached to stigma that are in our culture. It varies, of course, with race, the country of origin, our religion, age, all kinds of variables. And I've noticed in my practice that sometimes my doctor patients feel a little more, they feel stigmatized at first, but often when they get better, they don't actually feel the same degree of stigma. And they're more open to seeing this as a real illness, as a medical illness. So felt stigma, that's the interior stuff that I mentioned a moment ago. Again, references there. I talk about Dr. Sophie Spooner, who was a young physician in the UK who took her life about 10 years ago now, I believe. I've written about her in my forthcoming book. She'd been treated for unipolar depression, and that was enough of a struggle for her. But when the diagnosis was changed to bipolar 2, she had a lot of difficulty accepting that diagnosis because she felt so embarrassed about it and ashamed and was worried about her chances of getting married, of having children, of her colleagues finding out, et cetera, et cetera. And all of this came together, and her mom feels contributed to her death by suicide. So these are some examples of when we feel stigma inside. We deny symptoms because who wants to admit to stigmatized symptoms? We minimize the magnitude of it. We overwork. We think, maybe if I see a few more patients, I won't have these symptoms. We delay getting help because we're hesitant. We're embarrassed when we go to the doctor. And sometimes we lie because we don't want to share some of the things that we've been experiencing. So guidance for all physicians. It's so important that you have a primary care physician. Let that person be your doctor. When you do that, then you get away from self-diagnosing and you get away from self-prescribing. This third bullet there is an article I wrote about depressed psychiatrists who treat themselves. They've never gone to a psychiatrist for care. And I wrote that because I was trying to encourage them to try to find a psychiatrist to look after them. And in my research, looking after families of doctors who died by suicide. All of the doctors who died by suicide, they did not have a primary care physician. Oh, sorry. Okay, so fight the stigma that's killing doctors. And these are just some examples. That it's embarrassing at first, but you may feel better about it afterwards. And consider telling a colleague about it, or maybe your family or trainees. It's really a gift when you do that, and you make it easier for them to go get help themselves in their hour of need. I want to tell you about Rahel Gupta, who wrote a beautiful, beautiful story, painful story of her depression that occurred when she was a medical student at the University of Michigan. She took a year out, got treatment, and she produced this lovely videotape. It's only 4 minutes, called Physicians Connected. So you can look at that. I use it in my teaching a lot, and those of you who do teach may want to borrow that. She's now a practicing child psychiatrist in California. And Dr. Adam Hill, he wrote about his struggle with alcoholism, depression, and suicide, and just about killed himself. Fortunately, his wife, who was frantic to find him, called him and aborted the suicide attempt. And his article in the New England Journal of Medicine is very important reading. And he's also written a book called Out of the Woods. He's a pediatric oncologist and palliative care specialist, and happy to report that he's got in treatment and he's now well. This is another resource I urge you to have a look at. It's only 4 minutes long. We produced it for trainees. However, I've used it for medical students, doctors, all at every stage of career. So it's got a lot of message. It's very brief, but there's a lot of important life-saving tips. Getting stressed during training is normal. It can happen to anyone. If you're worried about a peer, not only should you reach out to them, but don't be afraid to ask them straight out, are you having thoughts of taking your life? It's very important to ask that. People will be relieved that you've asked. In the video, there are examples of what to say and what not to say, what to do next, how to get that person to help with your assistance, and a message that asking for help is the smart and professional thing to do. It's not weakness, it's the smart professional thing to do. I call this a proclamation. I don't know how many doctors I've looked after who are now well, who have said, I wouldn't be alive today if it weren't for my colleagues reaching out to me. I was so ill, I couldn't even make a phone call to ask for help, or I was so addicted to alcohol or other drugs and felt so ashamed, and they saved my life. So we must remember that. Reaching out saves lives. It's not about crossing boundaries, it's kindness, it's caring. We will reduce their suffering and we will save lives. Let me wind up now and conclude with some suggestions about wellness, striving for balance. Obviously, on the left, we have to pay attention to our health in all its dimensions. We have to pay attention to any previous history we might have had of anxiety or depression. We have to pay attention to feedback from loved ones who care about us and worried about us and are suggesting that we get help. Even if we feel kind of defensive at first, we have to pause, we have to calm down, and we have to listen and reflect that they're saying this because they care about us. So rest and sleep, that's so important. And we're seeing that, of course, in those 2 slides when residents are working such long hours and not getting the rest and sleep they need. Exercise, primary care doctor, don't let any job in medicine compromise your right to a personal and family life. Group relationship with our doctor peers. The Ballant groups were started in England some time ago. They're very helpful. Meditation, CBT, et cetera, et cetera. I want to tell you about Dr. John Budin. He's a psychiatrist who lives with bipolar illness. He's a friend of mine. He's a colleague of mine. And he has started an international support group for doctors with mood disorders. Any of you on this webinar today who are interested in something like that, don't hesitate to send him an email and he'll get back to you. As I say, it's an international support group. It's very, very helpful. And it helps with all of the stigma that doctors feel. The conclusion of a paper that we put together during the pandemic, Dr. Christine Moutier and my colleagues, myself, complex health outcomes, suicide. There are many drivers of risk, so we need a strategic, multi-pronged, evidence-based attack. This paper is very comprehensive in its purview, and you'll learn a lot by having a look at it. And these are my take-home points for all of you. We're all in this together. A tip of the hat to Surgeon General Dr. David Satcher, who over 20 years ago said that suicide prevention is everyone's business. Everyone. Don't hesitate to reach out. Consider sharing your story to trainees and colleagues. Be our brothers and sisters keeper, and practice self-compassion. Self-compassion, by the way, is not selfishness or that at all. It's got to do with treating yourself with the same dignity and respect and kindness and care that you give your patients. These are my appreciation comments. I thank Niki Mahjourian for inviting me to be with you today. I thank all my colleagues and mentors and my patients and students who inspire me. There are so many generous health professionals who have shared their personal stories with me, and they educate all of us. That's my phone number, that's my email, and that's my website where a lot of what I've said today is available. Okay. Let me stop my sharing.
Thank you very much. We have 5 minutes for question and answers. Dr. Malakouti turned his video on. I guess he wants to say something. Go on, sir.
Yes. Professor Myers, thank you so much from your very informative and interesting lecture. Actually, we have such problem, as you said before at the beginning of your lecture. We are facing with such problem during the last 5 years, and we had this enormous surge of suicide among doctors, residents or doctors. Any type of any level, and GP or professor of university, or particularly the residents. And they are doing something in the Ministry of Health and in the Iranian Association of Medical Council. They are doing some solution, and they are working hard. But however, I have two questions. One, some believe that because of a stigma that you mentioned very well, the doctors do not get in touch with other doctors to seeking help. And they are trying to establish a private hotline or private clinic or private, I'm not sure again, does it work or not because of that stigma? Maybe it is useful, but I'm not sure about that. And the second question is actually the physician, because of their they are very worried about the future of their professionalism, future of their work. So that is why they worry about, if I go to psychiatrists, if they make a document for me or mental health document for me, maybe I jeopardize my future job and professional. So let me know what's your idea. Thank you.
Yes, thank you very much, Dr. Malakouti. I'm going to take these in turn. The first question is a very important one. We do have a national suicide prevention hotline in the United States for medical students and for doctors. You can Google it, National Physician Support Line, I think it's called. It was started by Dr. Mona Massoud in the very early weeks of the COVID pandemic. I've interviewed her. It is a wonderful, and it does prevent suicide. They have over 800 psychiatrists who volunteer to work the phone lines, which it operates 7 days a week for about 18 hours a day. And I've done in-service training with them as well. So it does work. So I would strongly support that. And Dr. Masood would be somebody who would be helpful to talk to about that. The second one, the discouragement, we're seeing that in America as well, that there's a sort of sense there's just so much stress in the world, there's so much chaos, there's so many pressures in medicine. However, what we're finding though is if we all get together as a collective, that we are part of the solution. As you may have read, I mean, there's a lot going on in the UK right now about doctors striking and whether this is acceptable. The National Health Service is not very happy about it. Yet on the other hand, when doctors have striked before, sometimes there are changes made. Our young doctors have a lot of creative solutions and ideas, and we've got them working on many, many committees. I'm very active in the American Psychiatric Association. And as you know, if some of you are interested too, it's easy to join as an international member. But I think too, and just one final thing I'll say about this. I know that there are a lot of doctors who get burned out. On the other hand, though, there are senior clinicians who still remain very happy with what they do. And if they can act as mentors to physicians, and we have mentor programs set up in the state of New York, that helps as well for younger people who can see there is light at the end of the tunnel. I hope those comments are helpful, and thank you for your questions.
Thank you.
Are there? I'm sorry. Go ahead. You're muted. Oh, right.
Hi, Professor. I'm Niki Mahjourian, and I want to say thanks for mentioning my name in your PowerPoint, and I'm very glad to have you there.
Okay. All right. Okay. It's probably time for your next speaker, is it? Okay. So
we have two questions, if you could address them.
Okay.
One of them was that do you know of any connection between the MBTI? Yes, the MBTI characteristic and the rate of suicide? Can we use that in the guidelines?
I'm sorry, the MBTI? What?
MBTI, which is it's Myers-Briggs type indicator.
Oh,
yes.
You know that? Yeah. Those are things that are used as well, but certainly by psychologists when they're assessing personality characteristics across the board. But when doctors also have those kinds of, so they can be very, very helpful as we point out traits and we learn things that we then can work on with our patients. And nowadays, with such communication on the internet and artificial intelligence, obviously, it's many doctors find that some of these things are just helpful for themselves in terms of self-help. So I'm a very big proponent of continuing education. I know it's hard to keep up, and there's not always good things out there, but many things are good.
And then the second question was, do you see a role for AI in supporting young physicians and residents who are having mental issues and suicidal thoughts and things of such?
Yes. In fact, at the last meeting of the American Psychiatric Association was just a couple of months ago in Los Angeles. I was the chair of the scientific program committee. We had a lot of sessions on AI. In fact, there were so many submissions, we couldn't accept them all. And this year, we're seeing that there are many more coming in, which will be part of the meeting next year in San Francisco. Yes, but it is a work in progress, though, because there's so many things about AI that are adjuncts to the work we do that are so important. There are other things, though, that can be not only inappropriate, but actually harmful. So, but we don't know exactly what all of those things are. So that's why these things have to be studied very, very carefully. And that's why we've got, committees on the study of AI, things like that. But it's something that is with us, and we have to, work with it. And like so many things in medicine, pick and choose over time as we get evidence-based science.
That's okay. That's the end of the questions. Thank you very much for your comprehensive answer. And it was a great honor for us to have you here.
And thank you once again for inviting me. Good luck, everybody. I wish you all well. Bye-bye.